Hello friends and welcome. Tufts Health Plan is a Massachusetts-based health plan nationally recognized for its commitment to providing innovative, high-quality healthcare coverage to its members. Their HMO and POS products are ranked second in the nation, and Medicare Advantage HMO is ranked 7th in the nation by the National Committee for Quality Assurance (NCQA). Now available in Rhode Island, they offer an array of comprehensive coverage options with extras like discounts on gym members and other programs to help members stay healthy. Tufts Health Plan strive to set the standard for outstanding quality healthcare, service and value. Tufts Health Plan is one of the nation's most highly rated health plans. The company is distinguished for providing an outstanding member experience and access to quality care. Tufts Health Plan offers a broad array of healthcare coverage options to individuals and employer groups. Its tagline, "No one does more to keep you healthy," expresses a core commitment to offering plan members innovative tools and resources that engage them in enhancing their health and well-being and managing healthcare costs. Tufts Health Plan is a leader in advancing public policy discussions on several issues: prevention and wellness, affordability, and removing obstacles to accessibility. To improve the health and wellness of the diverse communities we serve, from traditional HMO and PPO plans to national tiered and limited network plans, Tufts Health Plan provides quality healthcare coverage across the spectrum of an individual's needs. In November 2011, Tufts Health Plan acquired Network Health, a managed Medicaid plan, making it the only health plan in Massachusetts to offer commercial, Medicare and Medicaid coverage. In mid-2011, Tufts Health Plan developed two new product offerings aimed at providing quality, affordable healthcare coverage: the Your Choice Tiered Network Option Plan, Steward Community Choice, a limited network community-based plan developed in conjunction with Steward Healthcare System. In 2009, Tufts Health Plan entered the Rhode Island health insurance market with a suite of HMO, PPO, and deductible plans. In December 2004, Tufts Health Plan joined forces with Cigna to offer CareLink, a national open access health plan that gives multi-state employers the advantage of working with experienced healthcare leaders committed to helping them achieve affordable coverage for all employees regardless of where they live. In 2012, Tufts Health Plan was the top-ranked commercial preferred provider organization PPO plan in the country and fourth highest ranked overall by the National Committee of Quality Assurance (NCQA). Its commercial health maintenance organization, Point of Service Option HMO POS combined product was ranked number 2 in the nation. This is the 9th consecutive year that Tufts Health Plan has been ranked among the top health plans by NCQA. The foundation's focus is healthy aging, improving the lives of adults aged 60 and older. The foundation funds more than $2 million annually in grants to non-profit organizations throughout Massachusetts and Rhode Island that elevate the well-being of older adults and help them live healthier lives. For 7 consecutive years, the U.S. Environmental Protection Agency has awarded Tufts Health Plan the Energy Star label for superior energy performance at its Watertown headquarters. Tufts Health Plan was the first healthcare organization in New England to earn the Energy Star label. Tufts Health Plan also has earned the Best Workplace for Commuters designation from the EPA. President and Chief Executive Officer James Roosevelt Jr. Founded in 1979 by Morton Madoff, MD, Dean Emeritus of Tufts University School of Medicine. Operational date 1981. Network 90 hospitals and some 25,000 healthcare providers. Membership, current membership 10,06,510, December 31st, 2012. Net worth $963.8 million, December 31st, 2012.
Are for just exactly the reasons that I'm arguing are the right reasons here. Greater complexity, and to the extent that we can measure it, greater quality. I'll say more often, greater complexity, and sometimes because of cost shifting. That is underpayment by governmental payers. We tend to not talk about one of the elements when we talk about all the successes in universal coverage. We tend to not talk about one of the elements that has not been a success, and that was the commitment of the state to significantly increase its payments to Medicaid providers that dropped by the wayside in the budget crisis. So those are factors. Sometimes we pay higher payments because of market power, because we are in negotiations, and whether that is because of the academic nature of an institution, whether that is because of the brand reputation of a group of institutions, or whether that is because of geographic location. Sometimes we pay higher payments because of those factors.
What would happen if you went to your contracted network and said, we're basically paying the same for all of our physician services and all of our hospital services, except we're going to account for differences in intensity of services based on the population served, and let's assume for now that quality costs more, so we're going to pay more for quality. What would be the response of your network?
Well, we do that in a fair number of our negotiations, and some providers respond enthusiastically to that. Some providers respond with growing accommodation to that.
Ellen, how would you respond if Jim said, I'm paying you the same as everybody else, except you got higher case mix, which you just told us about, so I'm going to adjust you for that, but that's it. Otherwise, let's say your quality was exactly the same as everybody else, so you get the same payment as everyone on the payment.
Well, I'd like to adapt that to something that I think is more usable than the question. And that is, I fundamentally believe a real fix in this market is to have a common fee schedule across all health plans. Not that we're all rate setting, we're not talking about the intense rate setting, but that fee schedule should be moderated with inflators in private negotiations, not state-run negotiations, private negotiations. So perhaps the hand of the state could come in and develop a foundation that's transparent, that we all know the basis of, that isn't different from health plan to health plan. And then in our private negotiations, we talk about the issues you raised, Michael, and that Jim spoke to, whether it's the fact that we have a high Medicaid population or a high case mix or a teaching mission, all of which are legitimate variations in price. So I think rather than talking about what's fair and what's not fair, we ought to do it more scientifically. And we ought to do it more transparently so that we have a common understanding that's irrefutable. And then we inflate it based on who we are, what our quality is, what our mission is, and so forth. And there's been a resistance to even thinking about that, and I frankly don't know why.
All right, well, your time is good since we've got the new Price Reform Commission to talk about new ideas.
Thank you for listening. Happy learning.